Thank you very much, Terrence, for the introduction. I'd like to thank Tom Farrington and Juarez Farrington and PHEN on their 10th anniversary. And so thanks again for being here for us. You know, when Tom first asked me to be the moderator, I'm really indeed an honor and a pleasure to be the moderator for this session, entitled the Prostate Cancer Among Young Men. I thought he thought I was young. And he said, wrong, you're just old. And I had nobody to fill the slot. So, that's, what he said. My episode with prostate cancer began, several years ago. I'm part of PHEN's Prostate Cancer Survivor Network. And I'm a retired military colonel, and my last command was at the Pentagon, and where I served in, combat as a hospital commander in Mogadishu, Somalia. And served in combat and said I never want to be in combat again. In 2003, I went for a routine prostate screening exam and was informed by my urologist that, Artie, your PSA is normal, but it's slightly elevated from the previous year. And because your father has prostate cancer, your uncle died from metastatic prostate cancer, I think we should do a biopsy. And I subsequently had a biopsy which showed that I did have prostate cancer. And at that time, I said, once again, Artie, you're in combat, but this time the killer is within. I successfully had a radical prostatectomy, and 11 years later, I'm still here with you, thanks to the PSA testing and the DRE. It is indeed my pleasure to introduce our next speaker, Dr. Kathleen Cooney, who is a professor of internal medicine and urology at the University of Michigan Medical School. In January of 2009, she was appointed chief of the Division of Hematology Oncology in the Department of Internal Medicine at the University of Michigan School and associate director for faculty affairs for the University of Michigan Comprehensive Cancer Center. Dr. Cooney is a highly respected physician scientist who, in addition to establishing an international reputation in the field of prostate cancer research, has contributed extensively to the clinical, teaching, and service missions of the University of Michigan. Her work on identification and characterization of genetic factors which cause or influence the development of prostate cancer has resulted in numerous significant contributions in that field. Dr. Cooney has scientific productivity is reflected in 87 peer-reviewed articles, 50 of which has been published in the past 5 years. Dr. Cooney will present information about the rapid increase in the number of young men being diagnosed with aggressive prostate cancer. Dr. Cooney.
Thank you very much for that kind introduction, and thank you, Mr. Farrington, for reaching out and contacting me several months ago. It's really an honor and a pleasure to be here today. Unlike many of the physicians who have spoken here today, I'm a medical oncologist, and I think sometimes that's not clear exactly what we do. So we are physicians trained in internal medicine who largely take care of patients with advanced cancers. So my practice is only in advanced and high-risk prostate cancer, and I see men, unfortunately, who succumb from the disease. But that's one day of my week. The remainder of my week is, as you heard earlier, is spent focusing on hereditary prostate cancer. And I'm going to start this talk sort of talking about hereditary prostate cancer and then move to how that research interest led me to my interest in early onset prostate cancer. So hereditary cancers, I think all of us know, particularly with Angelina Jolie, that there are genes that increase the risk of cancer. In breast cancer, there's been tremendous success in collecting families and using this family material to identify genetic material that segregates with cancers within families. These observations are critically important for science, for medical care, and importantly in families for understanding who's at risk for the disease. So using that context, about in the early 1990s, it was well recognized that prostate cancer clusters within families, just like breast cancer and colon cancer. So many of us jumped into this field and started collecting families with multiple cases of prostate cancer that could be used for genetic discovery. Next slide, please. So this is an example of a prostate cancer family, and for some background for those of you who don't look at this type of work every day, this is a pedigree structure. The squares indicate men, the circles are women, shaded squares indicate men with prostate cancer. So this is a family from our research project. The arrow indicates the proband, so this was the gentleman that I took care of at the Ann Arbor VA hospital a number of years ago. He came because he had advanced prostate cancer, and we were looking to see if he needed radiation or what treatment he needed. But when we got to the intake part where he told me his family history, I sort of stepped back and was quite impressed by this. So he told me all of his brothers had prostate cancer, and the one with the line through it, line means death, that individual actually died of prostate cancer at the VA in Chicago. His sister succumbed to breast cancer at an early age, and then if you go to the upper part of the pedigree, his father died of prostate cancer. He had 2 paternal uncles who died of prostate cancer. Focusing on the right-hand side of the slide, his one uncle married twice, and from both marriages, there were sons affected with prostate cancer. Interestingly, there's also a case of ovarian cancer in this family. So if you can imagine, you can kind of use your eyes and follow along. If there was one gene causing prostate cancer within this family, every single case of prostate cancer could be accounted for by that gene. So it was the recognition of these types of families that led many of us to get into the field of hereditary prostate cancer research. Importantly, in the context of this meeting today, this family is also African American. Next slide. So this is our most recent publication, and I think our highest degree of success in finding prostate cancer genes. So in close collaboration with colleagues at Johns Hopkins in 2012, we published information about really the only dominant, highly penetrant prostate cancer gene that's important in prostate cancer, and this is the HOXB13 gene. I'm not going to get into a lot of the science about this, but I think this is relevant because it's sort of this transition point where I thought, well, let's just not focus just on families, but let's focus on young men because they are at higher risk of having a genetic mutation that increases the risk of the disease. Next slide. So this is some data from the slide, again, from our publication. Again, I'm going to try to keep away from p-values and statistics, but if you can click on the... Dr. Isaacs and I collected all of the cases of prostate cancer that we had at Michigan and Johns Hopkins and typed these individuals, over 5,000 of them, for a recurrent mutation in the HOXB13 gene. And what we saw is if men had a family history, they had a twofold higher risk of carrying this mutation associated with prostate cancer. Click again, please. Similarly, if you had early onset disease, you also had a twofold increased risk of having this genetic mutation that's associated with the disease. So again, family history and early age of onset seem to be similar indicators of carrying this genetic mutation. Please click again. And if you had both, you had a 5-fold higher risk of having this genetic mutation. So again, these factors can work together toward helping us understand who individuals are who are at the highest risk of having this genetic mutation that increases the risk for prostate cancer. Next. So in the next 15 minutes, I'm going to review again, I think you've heard some of this morning. I'd like to again emphasize what the factors that are associated with the risk of prostate cancer. I'll focus in on some concepts in young men with prostate cancer and end with a call to action. Next slide. And please click. So this is ACS data. It's published every year in the beginning of each year, helping us as oncologists predict the number of cases of cancer that we would expect in the coming year. And as you've heard, prostate cancer remains the #1 cancer diagnosed in men as expected in 2014. Please click again. And I think importantly, I think sometimes when I put my internal medicine hat on, I think we forget, with this sort of pushback against screening, that prostate cancer still is the #2 killer in men in the United States, second only to lung cancer. And so I think as we've sort of backed off and we've sort of said, oh, men die with prostate cancer, not of it, I think we as clinicians and you as advocates need to continue to get this message out there that prostate cancer is the #2 cause of cancer deaths, and it's very important that we continue to look for it and treat it aggressively. Next slide. So risk factors. I think the risk factor we haven't heard much about today is family history, and I'll give you a little information about that. So family history, there has been studied extensively over the past 20 years, and there are a number of factors that we know that are associated with your own risk as it relates to your family history of the disease. So having multiple affected family members is a risk factor. The more members that have prostate cancer in your immediate family, that higher that risk. If individuals within your family have early onset prostate cancer, under 55 is the sort of cutoff we use in our research group, that also increases your individual risk of having prostate cancer, and the closeness of those relatives. So having a father or a brother is more important than if it's a cousin once removed. So again, so these are sort of factors that we use and we can use clinically to estimate risk of prostate cancer. Race, I think that's why we're here today. We know that African American men not only have higher incidence of the disease, but a higher mortality from the disease. And age, the risk of prostate cancer goes up significantly with advancing age. Next slide. So a little more details about this. One of my research colleagues put this together for me, to get away from data and so show some pictures to kind of drive home some pretty simple points. And this is a meta-analysis, so an analysis of many, many studies of hereditary prostate cancer, trying to drill in on numbers that we can use clinically for counseling patients. So in the upper left corner indicates the relationships of father and sons. If you're a man without prostate cancer and your father has prostate cancer, that increases your risk about twofold. Going on the right side, if your brother is diagnosed with prostate cancer, that's more important. It increases your risk about threefold. And on the bottom, if you have multiple affected first-degree family members affected with prostate cancer, your individual risk may be increased by a factor of 5. Next slide. I think we've seen this data, a different view of this data, and this is the incidence and mortality from prostate cancer across various racial groups within the United States. The second category is African Americans with a very high incidence and mortality from the disease. Next slide. But I think importantly, I think we've seen some of this data, but I want to point out that to me what's impressive, the top part of the slide is incidence by race, the bottom part is mortality by race. What we're seeing is a little bit of decline in incidence. So if the yellow line is the African Americans, there's this big upswing early on with the introduction of PSA testing. And then if you look at the current baseline, it's actually a little bit down. I don't know what that means. I start to wonder if that's an impact of reduction in PSA testing. I don't know. But the bottom part, to me, is most heartening, that we're seeing a decline in mortality. And I think some of us who are active clinicians like to believe it's the things that we're doing with improved diagnosis, active treatment of patients. Next slide. So the topic of today, though, really is age in my session. And this is the distribution. This is, again, SEER data from the National Cancer Institute showing the distribution of ages of the diagnosis of prostate cancer. The average age of diagnosis today is 66. And the focus of our research now is on this left portion of the slide, which is what we call early onset prostate cancer, men who are diagnosed at age 55 or below, which represents about 10% of all cases of prostate cancer. Next slide. So I'm going to drill down on this data in the next slide, but I think what's important, this is age-adjusted incidence of prostate cancer. I feel a little hard, it's a little hard to show all this without a pointer, but the top line is the oldest men. And the bottom blue line is men who are, ooh, thank you. Thank you so much. Let's see. There. So these are the oldest patients. This is time going this way. And this is the sudden increase in incidence of prostate cancer with the introduction of PSA testing. And if you go down, these are age groups, and we're getting younger. And this blue line here is the youngest patients, and you just don't see very many of them because it's less common. And so you can't really understand what's going on temporally because it's too small. Next slide. So if you blow that up and change the y-axis, this is what's going on with prostate cancer in younger men. So under age 50, a dramatic increase with no decline. So you don't see this upswing in incidence, just a continual increase in incidence in the youngest men under age 50 and men between ages 50 and 55. I was in my hotel room last night thinking about this, so I had to get on the web and do some PubMeding and to see if I could find any interesting data about this. One thing I found was a report, can't remember the source, that looked at interest in PSA testing in younger patients and described about a 20% use of PSA testing in a behavioral study. So I think a blood test for PSA is easy to get, and I was impressed that there was an increased sort of interest in PSA testing in younger men. Next slide. So who are these men that are getting diagnosed? You know, we heard today that most, today the U.S. Preventative Services Task Force recommended against PSA testing, where some groups are debating, when it should be used and at what age groups and who's at increased risk. But we certainly know that for many, many years when PSA testing was recommended, it was sort of put out there that family history is an important risk factor. So if you have a family history, those individuals are still going in and getting tested with PSA, and prostate cancers are being identified. There's also then those men who are seeking PSA testing. As I said, that I found some literature to support that as many as 20% of men in that 40 to 50-year-old age group, this was back in the mid-2000s when PSA testing was recommended, were seeking PSA testing. And I think some of these men are diagnosed with important cancers, high-risk cancers, and others may be low-risk cancers. And then finally, in some research interest of ours, we're starting to see men showing up with very advanced prostate cancers, metastatic, high PSA, the lethal forms of the disease. And this has been a research focus of ours. Next slide. But before I get to our research interests, let me talk about why is this important? Well, this is 10% of all prostate cancer cases, so if we're expecting 220 or 230,000 cases, this, 10% of that is a significant number of cases. So I don't think that, even though it's a small minority of cases, it really can't be ignored. The average life expectancy for males in the United States is in the late 70s. So this is, you're talking about men being diagnosed in a very active part of their lives. They're often working, and there's impact of being diagnosed. And then these men also have the chance to live longer, so they will suffer late recurrences for those men who have higher risk disease. And then I think that, even if men have curative surgeries or radiation, the consequences to health, like we heard from the last speaker with regard to sexual dysfunction or incontinence, have a longer time to have impact on the person's quality of life. Next slide. This slide is a little bit difficult to explain, but we, in our research group, spent some time using SEER data to try to understand whether prostate cancer in younger men is really more aggressive. This has been a hotly debated topic in the literature, and I think if you look at surgical series, younger men generally do better. They are younger, they have less comorbidities, their operative risks are much lower, and so if you focus on men having prostatectomy, usually young age is associated with a better outcome. But if you look at the disease as a whole, which includes men who show up with more aggressive or advanced forms of the disease, there's some evidence to suggest that as a whole, young men with prostate cancer may have, some of them may have more aggressive forms of the disease. So this data shows relative survival. And what it's looking at is the observed survival of men with prostate cancer compared to the expected survival, that is, men who are just living their lives and don't have prostate cancer. If prostate cancer has no impact on survival, the line should be at the top at 100%. But what you see in young men over here and very elderly men, there's a significant impact in survival on having a diagnosis of prostate cancer, again, suggesting that there are some aggressive cases that are really impacting livelihood in younger patients. Next slide. So we started observing this and working in this area about 4 or 5 years ago, and we were successful in getting Department of Defense funding for a research program, which my co-PI on this project is Dr. Scott Tomlins, who's a very successful pathologist and molecular scientist at University of Michigan. And we proposed to the Department of Defense that we wanted to identify these young men showing up with very advanced prostate cancers and sequence all of the DNA in their germline, that is your inherited DNA, all of the DNA in their tumor, looking for novel mutations, either in their germline or in their tumors, that were allowing these cases to show up. And just to bring this point home, it seems a little abstract just talking about it. This is a patient in our study who's actually a patient of mine who came in at age 49, had a PSA of 150. He went to his doctor and had been seeing his doctor for a couple of months complaining of back pain. And when you show up with back pain at a physician's office, prostate cancer is usually not high on the diagnostic list. And so it took a while to get to this diagnosis, and he had very, very advanced disease and actually eventually succumbed to this disease. And so it's the willingness of individuals like this to let us work and study their DNA that we're hoping to lead to new discoveries. Next slide. So what's the call to action? I think that the focus of this conference today is to continue to emphasize that we need to do more work and help African American men understand the risk of prostate cancer and understand that they're subject to particularly higher risk disease. I think we need to encourage men to engage in the discussion with their primary care providers about the risk and benefits of getting involved in a screening scenario. And, although I think we heard earlier, if you're showing up with symptoms, you have more advanced disease. In younger populations, because people aren't thinking about the diagnosis of prostate cancer, sadly, men are showing up. And I think my nurse practitioners here with me today, we see a number of young men showing up with back pain and urologic symptoms. And because the diagnosis of prostate cancer is just not high on the list, it kind of goes on for a while before the right diagnosis is carefully made. And so I think, although it is advanced disease, sadly, we're still seeing it show up in younger patients. And I think we just need to, sort of increase the awareness of early onset prostate cancer and perhaps focus more on that. Last slide. And finally, as a researcher, I spend a lot of time thinking about how research can make the world a better place. And as a medical oncologist, what we talk to our patients about, if you look at all people with cancer in the United States, it's about 5% of patients who actually participate in any form of clinical research study. And, in the children's oncology world, almost every single child is put on a research study. And they've had more active development of clinical trials and protocols in that regard. And I think it's partly on our responsibility as the physicians and partly on the patients to help sort of engage and partner to develop the right research studies to answer the most important questions. So thank you very much for inviting me to speak today, and I'm happy to take questions.
Thank you very much, Dr. Cooney, for that very informative discussion and presentation. Do we have any questions for Dr. Cooney? We have a microphone coming, sir.
My name is Gerald Green. I'm from Oakland, and I'm a prostate cancer survivor. My question, you stated that there were young people coming in 49 and under who had a PSA of 150. Do you have any statistical data as to what population of the community that is? It seems like that would be a strong support for having PSA at a younger age.
Right. So I think the problem is that if a patient shows up at when they're 49 and have a PSA 150, when would you have had to start screening that individual to find that high-risk disease? And I think this is, at Michigan, we are very closely working with our cancer genetics group to help to start to study some of these questions, because I don't think we know the answer. The goal of screening is to find disease when it's early, often asymptomatic, when you can impact and treat and cure the disease. And I think these are questions we don't know the answer to. But I think, I'm personally concerned that we're seeing a number of these individuals. They're uncommon, and we see them because we're a referral center, but they're really an area of very active research interest.
We have a question over here.
One of the problems we as black men faced, we cannot get into clinical trials because of comorbidities. Yeah. When are we going to change this?
Right.
It's all right saying we can't get black men, but then the door's slammed in our face for reasons that we're not always responsible for.
I think this is where I'd love to be able to partner more actively with people to help understand. When we write clinical trials, we write them with a certain goal, and that is to have people be able to tolerate treatments. And sometimes drug companies, pharma, pushes certain things. But I completely agree with you. There is nothing more frustrating than having to exclude somebody who I think is a good candidate for a research protocol just because the protocol was written in a certain way. So I completely agree with you. And I think one of the things that I participated in some conferences similar to this, and one of the ideas is to get patients to be more involved in the trial designs and trial preparation so that we as the researchers can be more cognizant of sort of some of it is unexpected and not, it's not anticipated, and it really isn't designed to keep people out, but it does. And I appreciate that comment.
Hi, my name is Reginald Tucker Seeley. I'm an assistant professor of social and behavioral sciences at the Harvard School of Public Health. It seems like that families would have to, or the men would have to have a lot of detailed family history information to participate in your study. So I'm curious, can you talk a little bit about sort of what are some of those challenges and how your research group sort of addresses that to help men gather all of that information?
Thank you. That's a wonderful question. some comments. I think, so my husband is a urologist. He doesn't practice prostate cancer, but what I see from my colleagues in urology is they talk about male health history. So they say, does your dad have prostate cancer, or your brother? But they exclude often the maternal side of the family, which is hard to ascertain information on because it's maternal grandmother and maternal uncle, and oftentimes we talk about grandfather, it's dad, and so we're going up the paternal side, so I think that's an important issue. I think in our, we don't often ascertain information on other cancers within families. Actually, or on Monday, our research team just submitted a grant looking at families that have both breast and prostate cancer. So in both white families and African-American families, there seems to be co-clustering of the diseases. So if you only talk about prostate cancer, you may be missing these breast, like in the family I showed with the breast and ovarian cancer. That may have significance. Maybe there's a BRCA1 mutation in that family. So again, I think that's an important thing. And I think as an active clinician, I can't tell you the number of men who show up and we talk about families, say, I don't think anyone in my family has prostate cancer. And you say, you know what? Go home and talk about it. We'll see you in a month, we start you on treatment. Go home and talk to your family members. I am shocked by how much more information comes out that way. And my research team can validate that. I'll say, I think this guy has a family history. Can you call him and work with him? And it's really quite surprising. So I think, again, that's another maybe call to action, is that people need to talk to their family members. Family, forget the genetic testing. Family history alone is a very important risk factor for prostate cancer. And so if we get people to talk about it, I think that would be a really good first step. At Michigan, we've in the process of developing an iPad-based tool to help collect family history. It's not quite ready for prime time, but I think the hard part with that, it relies on people coming in at their clinic visit with that information. So I think it might be better used in a follow-up visit rather than the first visit.
We have time for just 2 more questions, please.
Yes, yes, thank you. My name is Lorenzo Turner, and my question is in line with the family history. Now, my mother's family, she had 23 siblings, and every last one of them died from some form of cancer. Would that increase my son's? Now, I'm a prostate cancer survivor. Now, would that increase my son's chance of getting cancer or prostate cancer?
So let me answer 2 parts of that. The first is that there are genes that increase the risk of other cancers and prostate cancer, and most specifically BRCA1 and BRCA2, the breast cancer genes. Both of those genes mutations will increase the risk of prostate cancer, particularly BRCA2. Importantly, BRCA2 mutations often are associated with more aggressive forms of the disease. There are other genes that cause colorectal cancer, specifically the Lynch syndrome genes, and there's active research done, and some in our group, that looks at the MSH2 mutation, and that seems to also increase the risk of prostate cancer. So that's the genetic answer to the question. The clinical part is if you and your family are interested in understanding the risk, the best place to go is to a cancer genetics clinic and have someone help put the family together, the pedigree together, and help them understand what risks really are associated with your specific pattern of disease within family.
Thank you very much, Dr. Cooney, for that excellent presentation.